going to be all about the workflow from CT simulation all the way to the treatment site, and how we need to handle the images and what type of images we need and how the immobilization affects the treatment part. So this is the objective from CT sim all the way to treatment table. A very common question that I always get asked, especially by the therapist, is why do we care about being too focused on immobilization if we have a 6-degree couch, right? So is this the magical answer? And do we need a 6-degree couch for intracranial as well as extracranial? You know, the brain is well immobilized. It's not going anywhere. Can we do SRS without a 6-degree couch? So all these things, all these questions, we're actually still being asked until this day. So we're going to go through them quickly. So patient immobilization, there are so many options in the market. Again, we're not going to push one vendor over the other. There are a lot of good options over there, out there, and whatever you choose, the key is to use them properly. I'm going to present most common, not mistakes, but most common reasons that would lead to misalignment. So the first thing that you notice if you see a lot of SBRT cases is upper body roll. And roll means when the body part, I'm going to stand up a little bit, it's going this way. One reason of roll is when the hands are not sitting properly on the immobilization device, if they're kind of hanging in air. If the arms are hanging in air, then one side could be pushed a little bit more to the back than the other. تمام. وهذا بيؤدي I'm going to say a few things in Arabic إذا بتسمحوا لي. The upper body roll definitely is a cause of improper arms alignment. So if the patient does not have proper placement under their arms, you're going to have the upper body roll. Another thing that we always put is a knee sponge. A knee sponge makes sure that the knees are aligned, and hence you don't have pelvis rotation, right? So you have upper body fixation to prevent roll. You have knee sponge to prevent pelvic rotation. The other thing is when you put the patient on the CT couch, you have to make sure that they're aligned well with the sagittal laser, meaning a laser bisect them من أنفهم all the way to the pelvis. And you might think, and this is ABC of CT simulation. تمام. بعتذر للناس اللي already were doing this and they're doing this really wonderfully. But we have to iterate this because you do see a little bit of relaxation that happens after a while. Let's say you're focusing on treatment of somewhere in the chest, and so you don't care how the other body is aligned, other body parts. Wherever you're putting more stress, the entire body could either roll or rotate. And sometimes you'd have what we call a pitch. رح نيجي later on على تعريف different degrees of rotation. So later on what we have to do, مش later on, من البداية, you put the patient on what everyone knows as a vac lock or a blue cushion. It is a cushion that basically you put it under the patient, take the air out, and it contours to the patient shape. So what we do to prevent body roll, tamam, is to have the cushion go all the way up to mid-axilla. So as high up as you can go. And the idea, you have a support around the patient. Well, then let me just go down here. Right? So you want to make sure that you're aligning, you're fixing the body from going sideways. So don't go lower than mid-axilla if you can. Another thing we're trying to do is to have, as you can see here, try to have a little bit of definition between the thighs. So you're also fixing the pelvic bone. كل هاي الأشياء مهمة even if you have a 6-degree couch. If we're talking about upper spine, a head and neck, or even upper chest area, use what we call a 5-point mask. Either we say a 5-point mask or we call it a head and shoulder mask. Don't use a 3-point mask, all right? A 3-point mask only fixes the head, doesn't even do much for the neck. I want you to notice something. Notice how the chin has a more rigid structure here. يعني the face has a looser structure. لاحظ الماسك around the face خفيف. بينما we have a more rigid structure under the chin. Chin is important. Same thing in this, in this, what do you call it, image. See how the chin is kind of double bagged or double lined. Fixing the chin pretty much fixes your entire head and upper neck. What you want to do is pay attention when you're aligning the mask. You try to take all the contour around the neck. We noticed recently that our CT Sim therapists, they have loose mask. So you have a quite of a 2 to 3 degree pitch on the neck. So what we did a root cause analysis, and we found two things. We found that they don't give the mask enough time to solidify on the patient. It needs a good 15 to 20 minutes to take the shape. And then some therapists don't give a good definition around the neck and the chin. Nose, you can do the nose, but it's not a must. You can actually open the nose area if people need to breathe better. The ears, it doesn't give you, oops. Can you guys still hear me? Hello?
Yes, we are hearing you.
Oh, okay. Because my headphones told me that the call ended. And another thing that also we did is that we brought in one of the vendors from where we buy our masks from to give another training. So we try to have a training for the CT Sim therapists, a sort of continuing education type training every 3 to 4 months. And we told them that recently we've been seeing that the masks are not well matched. And there's a lot of 2 to 3 degree rotation pitch on the neck. So what he suggested is that when we're doing the mask, to have a sort of a pen and do a dimple where the patient, we create part of the mask goes inside the mouth and the patient bite on it. And we leave it until it solidifies. بصفي shape of the mask. And then there is a bite built into the mask. تمام? And then, of course, you do a better definition of the neck and the chin. But this is kind of a built-in bite from the mask itself. And this was his suggestion. This actually was last week, and we haven't implemented it yet, but it makes sense. If a patient has long hair, you need to pay attention, because if the hair is put underneath the head and the patient is sleeping on the cushion, then from day to day, you're delivering 4, 5, maybe 6, 7 fractions of SBRT, and the hair is thick, but it's not staying in the same location every time. So this could also do a little rotation for the patient head. So remove the braid if there's a braid and have the hair come out of the mask. Oops, excuse me. So we're talking about using different immobilization devices. We have this at our institution where I work right now. So what we do, we have this one over here. We have the blue cushion, and then we have the plastic with the vacuum, and you can suck the vacuum in. It's not very practical. But I should say it really depends on who's doing it. And it depends on you spending a lot of time to make sure that it's airtight. There's a lot of art. يعني فيها فن كتير وبدها وقت. But this is what we have, and this is what we use. And this is not our patient. I got this from the internet. So, whatever they have, that's probably a model. And remember what I talked about, having the arms sitting on a rest. And a lot of the new devices right now, they have a built-in armrest. So this is another device available in the market where you have a abdominal compression built in with this immobilization device. It has nice rest for the arm, it's a wedge, and you have the knee pads also built into the immobilization device, and you have places to put the feet. And immobilizing the feet is also important, because if the feet are not immobilized, they could rotate. And we don't have this option, but what we do when we put our patient on the table like this just a regular rubber band. So you have one of those heavy-duty rubber bands, and then you tie the feet together. Whatever you choose, the idea of patient immobilization is in stereotactic is to prevent rotation, the different types of rotation. If you're aligning and you are misaligned مثلا in and out, up and down, or left and right, that can easily be compensated by any couch you have, any neck couch you have. What is difficult to compensate is the rotation. Falan, we spoke about roll, rotation, and pitch. What do you mean by that? So roll, when the body is rotating like this, tamam? So what you have, your left side probably is higher than the right side, or vice versa. And this could even affect the entire body or just the upper part. You could just have a roll in the chest, but the abdomen and pelvis are aligned. Or you could have a roll in the pelvis, but the upper chest is fine. Another one is rotation. Rotation is the entire body is going sideways. And basically think about the rotation of a linear accelerator couch when it's rotating around isocenter. Rotation basically is the easiest to fix because definitely you can see it. You put the patient on the table and then you have the sagittal laser. So alignment, proper alignment with the sagittal laser from the nose bridge, chin, and you have suprasonal notch, xiphoid, etc. If you have that, then you make sure that you don't have any rotation. And that's the easiest. Pitch maybe is the most difficult to see, but it happens, and it happens a lot in the brain and upper neck. Think about pitch. If I'm doing this, if one time my neck is a little bit up or a little bit down. So that's what we call a pitch. And sometimes you do see a combination of all three together. So the idea of alignment is that you want to prevent the body from rotating. Everything should be exactly where it is. So now you put the patient on the CT simulator, you put the proper immobilization devices, you made sure that the patient is aligned with sagittal laser, well aligned, and cushion is going up to mid-axilla, so you're preventing all different sorts of roll. You have the knee wedge, if you have any head and neck mask, if you have any neck rest, etc. And then you think about motion management. And we covered this yesterday, so we don't need to talk about it. CT slice thickness, we mentioned it yesterday, but I'm going to mention it here again for emphasis. It's 2.5 millimeter for SBRT. And that's very reasonable. When we do SBRT spine, we could go 2 millimeter. If you want to go again, more higher resolution, 1.5, of course you could do that. But things in the body, which is extracranial, 2.5 to 2 millimeter is very good, reasonable slice thickness. Now here comes a question, and then please get the Zoom poll ready. What if I need to scan a patient with contrast and also do motion management? All right, so what do we do? And here are the questions, So what if a patient requires a contrast and motion management? The first option, give the contrast agent during the 50% phase. We've talked a lot about 50% phase being our baseline. This is the most stable. B, give the contrast agent in the beginning of the 4D CT scan and perform a quick scan. So maybe a 4-phase scan instead of 10. Maybe do a new scan just for contrast only, or maybe choose a form of motion management that allows for both contrast and motion management to be delivered at the same time. So let's see the poll. So that you're going to stop it when we hit 50%. So we have 50% of participants.
Well, we may allow more than 50%.
Sure. Let's see. So now we have
like 70%.
Yeah, we'll give it maybe 10 more seconds.
So D, B, and C. And I guess not everyone likes option A.
Wait, we haven't shared the results yet. Okay, 5, 4, 3, 2, 1. Okay, good job. Now
Right,
they can.
So we have 45 people, almost 50% say choose a form of motion management that allows for both contrast and motion management to be done at the same time. And we have quarter, 24% say make a new scan for contrast only. And 11 say give contrast during 50%. And we have 28 say give contrast and then do a very quick 4D CT. So let's look at C and D. We definitely have a majority, about 75% say that we could do that. And the answer is C and D. So you could actually have two options. And we're going to go through these options. So taking pancreas, for example, example 1 is what we do here. And I gather example 2 is what Ben does in his institution. So what we do here for pancreas, we do a DIBH. So patient is talked about DIBH. So patient is taking a deep breath. There's a screen that they can see where they need to take the breath in and they hold it for at least 20 seconds. We inject the contrast material. And then for venous and arterial scan, there is a time delay. There's actually an RTORG protocol that talks about this, and there's a lot of publication. So we do our motion management, which is DIBH, and the scan for DIBH also contains the contrast. So this would be option C, right? No, option D, which is it's the same scan, including DIBH and contrast.
Sorry, Dr. Shada, but the chat is disabled.
I'm sorry?
So we can't. Chat is disabled for us.
You cannot see my screen?
I don't know why. I see the screen, but the chat for question, it is disabled. I don't know why.
Chat is disabled?
Yeah.
I don't know about that. Ben, can you see the chat? Why is it disabled?
The chat should be open to everyone. I see other people able to type in the chat.
No, it is not down. It's now disabled.
Oh. Okay.
Yeah, it says chat disabled.
Also, there is disabling in our side.
Oh, okay. Thank you so much. I will try to fix that. Sorry. In the meantime, Shada, you can continue. I'll let you know when
I just left the chat and came back to it again, and now I can see it. So if you could close your chat and open it up again.
Oh, okay.
I think now it's working.
Yeah. Right. So
Okay.
the other option, and Ben can maybe discuss this because he does it in his institution, is that if they cannot do a DIBH scan, if the patient is too frail, cannot hold their breath, then they do 2 scans, an initial scan with contrast, and that's very thin slices, 2 millimeter slices. And then they do a 4D CT scan from motion management. Part of motion management is phase gating because patient cannot do the IBH. Is this correct, Ben?
Yes. So at our center, doing a 4D CT scan takes a longer time. The contrast only stays in the body for a short amount of time. So we wouldn't be able to do the 4D CT and the contrast together. It would be an incomplete study. So instead, we do the 4D CT scan, and we'll do another scan. It's just a free breathing, it just takes one picture. And with that free breathing scan, that's just like a normal CT sim scan that you do for other patients. And you can use contrast for that. It will be a thin slice scan. So it provides high resolution with the contrast. And then when we're doing the contouring, we'll have both pieces of information. We'll have the information about the range of breathing with the 4D CT scan. And we'll have information about the anatomic detail with thin slices and contrast with the contrast scan. And then it is a bit of an art how to use these together. It requires proper registration and fusion. Hopefully that helps answer.
Yeah,
Right, so
Ben, and
sorry,
I just have a question. Ben, the scan number 1, which is the contrast scan, it's not venous or arterial, it's just a scan.
So it depends. If you are doing like a liver SBRT, then we just do a scan. Like we don't pay attention, is it venous or arterial? But if you're doing liver SBRT, now there's an important difference between the venous phase and the arterial phase. So for liver SBRT, When you're doing that contrast scan, you want to do one that's a venous phase, and you want to do one that's an arterial phase.
So yeah, so if it is pancreas or liver, we do 2 phases of contrast CT, then the 4D CT scan. So we will have a 3 setup if we are dealing with the liver and pancreas. Am I right?
Correct.
Okay,
You can
thank
see
you.
that in example 1, scan 1 venous phase, scan 2 arterial phase, and then
4D.
yeah.
Okay, thank you.
While for the lung, doesn't matter.
For the lung, whatever you use for motion management, we don't usually give the contrast agents for lung. Or you could use the IBH for your pancreas. And then, so for liver, we use chest compression. And for pancreas, we use the IBH. And so basically, it's just a single scan that includes both the motion management and the contrast image.
We have
so
also
it depends on what you have. Ayman, go ahead.
Isam is raising his hand from Morocco. Any question, Isam?
You're muted. If you want to ask a question, can you unmute yourself or write down the question in the chat? I don't feel that if you cannot understand proper what I'm saying, because I know إخواننا في المغرب, maybe they're not well versed in English, they're more versed
raising the hand.
In French.
Yes, hello.
Yes, go ahead, Sahar.
I have one question about the CT scans. If we are doing 2 CT scans for the patient, one with contrast and the other for the CT, which is the optimal one for contouring?
This is next slide. So thank you for the question. If you only have, so now we want to send the images, the CT scan for planning, and there's only one CT scan, then life is good, right? If I'm doing chest compression with contrast, or I'm doing the IBH with contrast, then you push that single scan to the planning and you work with it. One note of caution is that if the contrast produces artifacts, then the physicist or the planner needs to contour those artifacts and assign a Hounsfield unit or a CT number, right? Because the patient will be treated without contrast, make sure that the treatment planning system is calculating without the contrast agent. Only if you have a lot of artifacts. Now, let's say you're doing 4D CT scan. As we mentioned yesterday, but it's good to iterate here again. When you're doing a 4D CT scan for the lung, for example, and this is no contrast, just 4D CT, you want to create an average scan. So average scan is called average or mean, depending on the scanner that you have. So you need to get to know the terminology of the CT scanner software. And this is sent to the planning system. And then you also want to create the maximum intensity projection. Now I have to emphasize here, because I don't see it in the slides. Sometimes when you look at your slides with a different eye, you realize you haven't added few sentences. The average scan that you create and the maximum intensity projection scan you create include only the phases you want to treat the tumor in. Basically, the middakirin, those are the phases where the tumor moves 5 millimeter or less. So if I see that the tumor is moving more than 5 millimeter in the 10%, 20%, and 90%, I don't exclude from the average. So we tell the computer to just create an average scan from whatever phases that has a 5 millimeter or less tumor motion. And the same thing for maximum intensity projection. You push both average and MEP scan to the planning system. We've been asked by one clinician, one or two, we have 9, two clinicians, that they also want to see the full 4D CT phases also pushed to the planning system. They want to verify with their own eyes, I suppose, that when they create the ITV, that the tumor is moving within the ITV envelope as we say it is. And it's, and they want to measure the motion, on their own, which is another level of second check. And that's really good. Other physicians, other radiation oncologists, they don't want to do that. So whatever we tell them is a gating window, they will take it as is. So we just push the average and the MEP scan, and then they start contouring. Tumor delineation is done on the maximum intensity projection. Up until 2 years ago, the institution where I work in right now, they used to do the tumor delineation at the 50% phase. However, now they changed 2 years, since 2 years, they changed the practice, and now they draw the tumor on the MIP, on the maximum intensity projection. So that then you create a very clear ITV. Organs at risk and planning is done on the average scan. So it goes without saying that both scans, the average and MIP, are of course registered within your planning system. And if they're created from the same data set, they should already come registered. لأن نفس الcoordinate system, نفس الDICOM header, نفس everything. So should all, they automatically should be registered within your planning system. If not, just verify that, they are well registered. So you have the tumor delineated on the MIP, or on 50%. As I said, the institution where I work right now used to do 50% delineation more than 2 years ago, and then they changed to delineating on MIP. And then that delineation is then put into the average scan or the mean scan. And that's where we do our organ at risk delineation as well as a treatment planning, right?
Asking to repeat the slide in Arabic. Abdominal compression, is there a need for 4D CT, and we can use the contrast and do 2 phases? So these are the 2 things that...
When we do abdominal compression, we don't do 4D CT except for one doctor. الفكرة إنه الabdominal compression restricts the diaphragm expansion. So the patient is really breathing very shallow. And that's it. So you do abdominal compression, inject patient with contrast, and then you do the CT scan. You just only have one data set. هلا عندنا طبيب واحد. He's very meticulous. He's very number oriented. So we have just طبيب واحد بقول لك حتى مع الchest compression نعمل chest compression مع الكونتراست. This is our CT scan, تمام. بس بعدين بنحط البلوك and we do a 4D CT study فقط لنثبت إنه the tumor is moving less than 5 millimeter or less عفوا.
And this is actually like our practice in Canada also. Even with abdominal compression, we'll do 4D.
So that you verify that the tumor is moving, 5 millimeter or less.
Yes.
تمام. بس هاي تستخدمها, so you just use a 4D CT scan just to verify إنه your compression is good.
Well, and if the compression is not adequate, then you might need to use the 4D CT scan for actually your contouring and figuring out what ITV to use.
Yes.
Yeah. Now إذا عندنا 4D CT scan, let's say بنحكي عن متر, هدول بنشيلهم من السكان. بعدين بنعمل average scan. في بيكون عندكم option بالCT Sim software إشي اسمه average أو mean. تمام؟ فبتقول للكمبيوتر الفيز بعدين تبعتهم على planning system. Average is 50% phase, a little bit blurry because it's taking all the different motion into account. And it's not too blurry because it's 5 millimeter or less scan. والplanning حتكون very crisp. اسمه maximum intensity projection. So the maximum intensity projection. The lung is a low density tissue. وبعدين أنت عندك the tumor is solid tissue. تمام؟ So more solid and higher density من اللung. الماكسيمم intensity projection فعليا الكمبيوتر حيحط اللung فوق بعض different phases اللung فوق بعض بكل slice. So maximum intensity. The tumor is very crisp and very clear, واضح جدا. مثل ما حكيت, you have 2 options. You can do delineation على 50% phase. Remember, 50% is the most stable phase and less motion artifacts. Or you can do the tumor delineation على الميب بحيث تاخذ بعين الاعتبار يعني حتى ال small variations بالlocation of the tumor. عندنا الميب نبعته للplanning system على planning system والplanning. And what if we have 4D CT مع contrast? الكونتراست واضح هنستخدمه for tumor delineation. وال 4D CT الافريج سكان تبعها راح نستخدمه for the planning system. الآن ممكن شخص يسأل what about الميب؟ الميب it's only a concept في اللung. maximum intensity. بدي أعمل تمايز ما بين التيومر ما بين الباك جراوند تبعه. عندي maximum intensity projection. في الليفر if we're talking about pancreas we don't really have MIP. في ممكن تستخدموا minimum intensity projection but we don't use that. I think بعض institutions use it. I'm not sure, we can ask Ben, but we never use minimum intensity projection. So for anything outside the lung, in the abdomen, we push the average scan, and this is what we do in normal organ at-risk delineation مع planning. With contrast scan بيكون هو for tumor delineation. I don't know, and then do you guys ever use the minimum intensity projection for liver or pancreas?
No.
Okay.
No.
So so it's there, it's an option in the CT simulation software, but it's not really useful. I haven't seen it to be useful. So for anything that is not lung, you don't need to worry about creating a MIP or a maximum intensity projection.
There are two raising hands. Again,
Sure.
Sahar, you have questions, go ahead, please.
Yeah, just first question, Dr. Shada answered. It's about minimum intensity projection. So I think it is useless. I didn't see any.
It is useless.
Use it. Yeah. Second question, is there any device except RBM can be treat selected phases of lung?
I'm not sure, Saraha. I haven't used any other device than RPM. So does anyone know if we have any other devices in the market that you can do gating for?
Gating for selected phases, yeah.
Yeah, صراحة ما أعرف. I haven't used that before. I haven't used anything else before. إذا في حدا من الaudience who are using something different than RPM, please let us know. We answered her question.
Okay.
Yes.
I have a question, please.
Go ahead.
If we have on the treatment planning system in the 4D CT scan an option which we can see the motion of the tumor after contouring, after contouring, make a window in which we can see the tumor moving, and we make sure that the BTV is covered the motion. Is it necessary to make the contouring on the maximum intensity projection, or it is enough if we have this option in the treatment planning system?
So contouring, you can either do it on MIP or you can do it on the 50% phase. But if you're importing all the phases to the planning system, then you contour on 50%. And instead of exporting MIP, you can also contour on the 40%, 30%, 60%, 70%. المهم, just make sure إنه when you contour the tumor, the motion is 5 millimeter or less. المip on every phase will phases حسب إيش أنت عندك. المip saves you time. But definitely you can contour on every phase that you have.
Yeah, Shada, is it okay if I draw and really quickly show how I do it?
Sure, go ahead.
So if we have a tumor, we know we want to contour it. I begin by saying this is for a 4D CT scan. I will start by deriving the average scan or the mean scan. And then on that scan, I'll find the tumor and then I'll contour it. Okay. That's where I start off. And this is my GTV. Next, I want to know what is the motion. So I want to know how high does it go? And I also want to know how low does it go? Because remember, this is just an average scan. And in order to know how high it goes, what Shada is saying is that, we have the phases of breathing, 0%, 50%, back down to, I guess, if this is 50% and this is 0%. She's saying that she will go to the 50% scan. So now this image is going to look different, and we're going to see that the tumor has risen during the maximum point of exhale. When we're on that, looking at the 50% scan, then contour how you see the tumor there, right? And then you want to see, okay, so that's going to be the highest point of the tumor, and you make sure you're very specific on the very top of it. And now you want to see what's the lowest point of the tumor. So then you want to go and look at the 0% phase. This is going to be the maximum point of inhale. And so when you look at that image, you're going to see the tumor is looking lower. and then you're going to contour how you see it looking lower. After this, you'll probably want to interpolate to get to everything in between. And this is going to help you have your ITV.
So one thing, we don't interpolate because some of the tumors, they do a helical motion. So at different phases, they would have different right, left,
right,
differences,
okay.
or anterior, posterior differences. It's not just
right. Okay, so maybe I should say you want to fill in the gap. Interpolate might not be exactly correct. So the way that I do it is I play the video. I look at the tumor rising and falling, and I keep watching it rising and falling. And as I'm looking at that, I'm seeing how it moves in between here to here to here, and maybe it's jiggling its way downwards. Maybe it doesn't move straight up and down. But when you're looking at it moving, and you just want to make sure that all parts of the movement are covered in your drawing, which is going to be your ITV. I hope I explained that correct.
Repeat some of the slides from yesterday's lecture. I think now people have time to digest the information and maybe read up a little bit on it. So I could go back towards the end when we finish and repeat some of the slides of yesterday's presentation.
Okay.
If it's worth. All right, thank you, Ben. One exception is that 50% should be the valley and 0% is the peak, because 50% is exhale and 0% is inhale. So they're flipped, but we're not going to dwell too much on this. So now images for planning. So now you've done your CT simulation. You pushed the CT sim to the planning system. What other images do you need? Clearly for lung, you have already a PET image, a PET scan for the lung. I guess this is very well known, very popular. For prostate, I learned new things actually, that we use different R sequences. And don't tell me how to get these sequences. I'm not an MR physicist, I'm not an MR expert. But what I have noticed is that physicians who are doing prostate SBRT, they look for lava and water scans so that we could delineate the fiducials. Our SBRT prostate patients always have at least three fiducials implanted in the prostate. So we don't do prostate SBRT without fiducials. And as you know, fiducials don't have a lot of water content. And so they don't have a lot of hydrogen nuclei, so to speak. So they don't show nicely on a regular MR scan. If you do what is called a lava or a water scan, then you could see the fiducials. You could, kind of know where they are. So we delineate the fiducials using lava and water. And then there's something called 2T cube scan, 2T cube volume scan. I don't know the difference between it and a regular 2T scan, to tell you the truth. But we use this for contouring the prostate itself. Now, when I first, joined this institution, and then I was doing prostate SBRT, I'm thinking, all right, so I have these MR scans that I could see to some extent the fiducials on, and I have the CT SAM that clearly I can see the fiducials on, right? I just do fiducial to fiducial registration, and yay, I'm done, and I pushed it to the physician. The feedback came is that when we're contouring the prostate, what we care about is the urethra. So you want to create, you have a hot, or you have your prostate getting your prescription dose, and then you want to create a cold, not hot. You want to create like a cold middle where the urethra is. A cold is, of course, relatively speaking, it's still getting dose, but it's getting lower dose relative to the prostate gland. So when we're doing registration between T2 and between the CT for prostate, we actually have to do the prostate to prostate registration, and that is extremely difficult. You could barely see a prostate gland on the CT SAM. At least to me, it's difficult. So what we end up doing is that if I'm taking a case, I'm doing this prostate to prostate registration, and then I always send a note to the physician, please review and, fine-tune the registration as you see fit. Because definitely if we're going to spare the urethra, if we're going to spare, 3, 4, 5 gray to the urethra as opposed to, the entire gland. So a little bit colder than the prostate itself. Delineation has to be extremely accurate. So we don't do fiducial to fiducial registration. We do a gland to gland registration. And this is at least what the practice we're doing here. However, we still use the lava and water to delineate where the fiducials are, because we will use the fiducials to align on the daily session for the patient on the LINAC. CBCT quality is already worse quality than a CT SIM. So you will have an extremely hard time finding the prostate on a CT SIM. In this case, you only have to depend on the fiducial themselves, right, to align the patient on the table. For spine, the physicians have been asking for T1 and T2. T2 in order to clearly localize the cord. The CSF will look very white on T2, not very white. There's no very white. And then T1 is used for the contrast. T1 is used for the lesion delineation. For the spine, the MR are usually given in 1 millimeter cut. And so you'd have a very high resolution MR scans, axial scans for both T1 and T2. So then whatever you have from the CT SIM, you're dealing with contrast images from CT SIM, or you're dealing with motion management images from CT SIM, and then you're adding to it all these other, all these other images, diagnostic images. For spine, when we're doing spine registration, if this MR spine was done after the CT SIM, and we do have, we're trying to have the MR for spine done after CT SIM, similar to intracranial SRS. We do CT SIM first, and then we send the patient for MR. It takes a lot of cooperation and coordination with the diagnostic imaging department. So we're not always successful to have this workflow done. However, if we ask them to just concentrate on where we want the scan to be done. And this is very badihi because the spine is curving, right? So you don't want to be worrying about having to do a different cuts of the spine. And then what do we do for registration? So you just focus on that part of the spine. Now, let's say that you do a R scan first and the imaging department did not receive, say, just concentrate here. So usually they would give you a full scan, or they give you a full thoracic scan or a full lumbar scan or a full cervical scan. And then we know even if you go with the thoracic spine, the curvature changes. So basically, when you're doing registration, concentrate on the region where you're doing the registration. Concentrate on the vertebra that you'll be treating. I have seen at most 2 vertebrae being treated for SBRT. I haven't seen more than 2 vertebrae. 2 vertebrae were the most. We can ask Ben and Light if they've treated more than 2 vertebrae for SBRT, but in the practice where I worked at, 2 vertebrae were the most. So we just concentrate the registration on those 2 vertebrae, regardless of how the different spine curves above or below this region of interest. Okay, so now you have your images, you have the plans ready, you have the contours ready for planning, and then you do SBRT planning, and that's something covered in a separate lecture. We're not going to go over it here. You finish the planning, you push everything to the LINAC side. And people on the LINAC side either will love you or will hate you, depending on what you produce. Before we go to that, here's another question. On the LINAC table, if you have a 6-degree couch, then patients sit up, should take as much time as possible. Take your time, do it quietly, calmly, and then you use the couch, the 6-degree couch, to just fine-tune any discrepancies. Second option is take as much time you need to align with the X, Y, and Z, so that the table in and out, table vertical, table lateral. And then the 6-degree couch will correct for any rotational inaccuracies. Third choice is you do very quick alignment on the couch, and then we have IGRT, correct? We have CBCT, we have KV images, and we have a 6-degree couch, and then we let the 6-degree couch and the imaging correct for any rotational and translational errors. All right, so let's see. Ben, can you start the Zoom poll? if we still have Ben with us online. Ben? Oh, yes, thank you. So which one you think, if you have a 6-degree couch, what do you think? Do we still spend so much time on the table and just fine tune? Or we do quick, now we are able to do quick immobilization, quick patient positioning, and then IGRT and all the technology takes care of everything, or somewhere in the middle. This is a tight race.
Good. Let's give about
60% of participation.
Okay, take a few more seconds.
We actually have a Gaussian distribution.
4, 3, 2, 1. Let's share the results now.
Yes.
Nice job, everyone.
So according to the responses we have, most people, that's 51%, about half say we do a middle alignment, meaning we don't spend too much time on doing a perfect positioning. We just align with XYZ and we let the couch do the 6-degree or the rotational correction. We have a considerable 20% who say we do things quickly. Yalla, 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 marida al tawla, finish everything. And 30%, 1/3, who say, no, we'll take our time. The couch is just to fine tune. And thank you all for your participation. And we always have a hard time going to, hold on. The answer is A. And this is a very common misconception that a 6-degree couch is a magical bullet, that's a magical solution. And it's not. It will help us with patient positioning. It will not correct for everything. And let me show you, again, real life scenarios of patients that recently I come across. So you have on the planning system, they actually show better because you could play with the window and leveling. But at least let's see what we have here. You can definitely see the outline of the mask being nicely attached to the patient. And here you can see the outline of the mask. It's loose. Now remember this, if you look at me, this thing is a pitch. Your couch can do a pitch. And if pitch is the only problem we have, then that's fine. But sometimes you have pitch and you have other rotations. Again, your couch can do pitch, roll, and rotation, but it cannot do deformation. Yani, it can pitch, it can rotate the entire patient like this, but it cannot do pitch just for one part. So if the entire head with the neck has this pitch rotation, the couch can do that. ما في مشكلة. But if you look now at the figure over here, not at the figure, at the image, only the neck and the chest, the neck and the head has a pitch. So what you expect is that the couch only wants to rotate this part. يعني كأنه نعمل deformable rotation. The couch cannot do that. I cannot move just one part of the couch in the pitch direction. The entire couch has to go like this or like this. So if the entire patient has a pitch, يعني كيف? يعني if you look at me, the entire patient is this or this, then the couch can account for that. But if my upper neck is fine and just the chin is like that, this cannot be corrected, right? Because this means that part of the couch has to go up and then the rest should stay, and you cannot do that. The couch is not deformable. So what you end up doing, you end up compromising. Yani, wasat is not good enough when you're doing stereotactic. And also look at here, this is the same patient. If you look at the coronal cut, you see that its mask is nicely conformed to the lateral sides of the tumor of the patient. Bainama here, because of the the patient is not well aligned within the mask, it's very loose. So now what do you do? The question is, what do we do? The practice in North America is that for every stereotactic patient, when the therapists take the CBCT image, then they call the physicist and they call the radiation oncologist. And we have to verify the position of the patient. What you don't want to do you don't want to be just looking at where the tumor is, because then you'll be missing the bigger picture. You'll be missing if the patient is well immobilized or not. You always want to start with looking at the macroscopic picture. So we want to make sure that I can see the mask and I can see that the patient's chin is well inside the mask and everything is fine. فالآن, if the patient is well aligned inside the mask, and if we have any rotation, it's going to be the full entire body rotation, and that is easily compensated by the couch. The couch can move كلها كقطعة واحدة. But if I have one part of the body, and this is a head and neck, this is a head and neck tumor, and this part of the body is well immobilized, but the upper part of the body is rotated. معناتها نكسر الكاوش، لازم نكسر الكاوش من منطقة. We cannot do that, right? It doesn't happen. And you can see another example over here, where you could see that the chin is nicely forms inside the mask. This is CT SIM. And then when you go to the treatment plan, to the treatment side, there is a improper immobilization inside the mask. But all these things, هاي الأشياء كلها, you need to see it when they call the physicist to the machine. And by the way, the physician will be probably looking at the tumor. So the physician will have the focus, microscopic interest where the tumor is. The physicist need to look at the bigger picture. The full immobilization. Is a patient nicely fitting inside the mask and lung, the arm position, because the arm position would affect an upper part of your lung if you're pulling a little bit up or down, upper part of the chest. If the patient is well aligned inside the immobilization device, and then you can zoom into where the tumor is. So the process we have at our institution, when the patient is on the table, the SBRT or even SRS patient, and then the therapist, they do the immobilization, they do their whatever KV they want to take for gross alignment, and then they do a CBCT, and then they do the alignment between CBCT image and the CT SIM image, and then they call physics and physician. We try to answer the call first, like, faster, because we want to make sure that the gross alignment is proper. We want to make sure that everything is fitting nicely. Patient is well aligned inside their immobilization device. And then, once you do that, then the physician come, and then you can, at that time, then you can do a focus, a laser focus where the tumor is. فعندك macroscopic alignment, تضمن إنه the patient is aligned well inside the mask. And then if you do that, and then you concentrate on the tumor. If patient alignment is exactly as it is from the CT SIM, then any correction will not any correction with 6-degree couch will not compromise any part of your treatment. تمام?
A question coming, was the tolerance of rotation angle for the 6-degree couch you can accept for SBRT?
What do you mean with the tolerance?
Maybe Mahmoud, can you elaborate on your question?
Yeah, how much of the simulation?
We correct any discrepancy. يعني ما بنقول والله 1 millimeter discrepancy خلاص. If the alignment or registration between CT SIM and CBCT tells us no, we need 1 degree, 0.6 degree, ولا 1 millimeter, ولا 0.6 millimeter, we correct for it. تمام? We always correct for it.
No. My question concerning about set up the patient.
Oh, استنى عليا. Coming in the slide after this one.
Okay.
This is right. This is actually a very good question. لأنه نتصارع في, I would say maybe on monthly basis عندنا بالinstitution. A therapist في عندهم, they're pulling to one direction, physics is pulling to the other. So it's a real life situation. This is coming after this slide. So if you're doing a cone beam CT on the abdomen, chest, abdomen, or pelvis, it is not a large field of view. So you'd have missing data, missing body contour, which will affect the alignment, the gross alignment. And in this case, I'm showing you a case of lung tumor. And you can definitely see in cone beam CT, this is the smaller one. The green shape here is the green shape from the CT simulation. This is the body contour that's coming from the CT simulation. And definitely you could see that, well, we don't have enough information actually to say that the contour, the body contour is aligning well or not. So we are at a disadvantage already. If you also look at the coronal and sagittal cut, definitely we cannot see if we're aligning well to the body contour or not. So what do we do in this case? We try to use as much information as possible. Again, don't just focus on the tumor, because if you focus on the tumor, you could have different shapes, different deformable rotation that you need to apply that your couch cannot do. Your couch cannot deform. Your couch is going to move يعني قطعة واحدة بهذا الاتجاه أو بهذا الاتجاه أو بهذا الاتجاه. I cannot move this part one way and this part another way. So what we try to make sure that the patient is aligned properly as much as possible. These scenarios are very real. The field of view of a cone-beam CT is limited. So in this case, we ask the therapist, step number 1, يعملوا alignment between CBCT and the CT SIM with the entire full data they have. Even though we're only treating right lung tumor over here, tamam. But in order to make sure that we don't have any gross misalignment. So we could use the spine to direct us in one direction, and then we could use also both lungs as much as possible to direct us where we are. And we're lucky here to also have, you could see the aorta and you have the heart. So you use as much as possible of the information you have to align. If things align properly on a large scale, and then they go back and then they focus on the tumor. So if we need to a pitch with 0.6 degree for the tumor, that's fine. But as long as we make sure the entire volume as much as possible is aligned. And this would take probably several times back and forth لغاية ما يضبطوها يعني لأنه again واضح we are missing a lot of data from the cone-beam CT. It's a very good question. So تحط البيشنت على الطاولة, everything looks good, and then you do your alignment. And then you come here and you see we have a couch rotation of 2.1 on November 10, ثم اليوم. And then the next day you have 2 degree couch rotation the next day, right? Interestingly enough, the patient was planned with couch 0. So we have a plan that has couch 0, and you can see the planning parameters in dark blue. So 0 here is a planning parameter. And also you can see here, couch vertical is 10. However, we have couch vertical 12.2 cm. بالعربي يا لهوي في عندي 2 cm difference. And then the next day we have a 10.9 cm in vertical. So what's going on? An idea إنه if we're trying to match the tumor, you have this rotation, pitch, and roll in the patient on day to day. طبعا after you do all you can to align the patient well, you would still have those small discrepancies. And when the couch changes, a 6 degree couch changes itself عشان to align with the tumor, you probably will end up with a 2 degree with a 3 degree alignment. In this particular planning system, في عندنا شيء اسمه couch vertical وفي عندنا شيء اسمه couch vertical ISO. تمام؟ And ISO is right here. And the couch vertical ISO is 10 as I expected. Well, 10.1 ب 10 11 و 10 ب 11 11. And what's the difference between couch vertical ISO and couch vertical? Couch vertical هو الابسولوت نمبر. طيب هذا يخص this planning system only. والناس يستخدموه يعرفوا أي planning system هذا. But probably you also have something similar in the record and verification إذا واحد ثاني if you have a different record and verification. This is ARIA to be exact. And couch vertical ISO هو concerning the tumor itself. So after correction, after 2.1 degree correction, and after almost 2 cm correction in the vertical, then we have a proper alignment of the tumor. This is called couch vertical ISO. Something similar if we're doing couch lateral. Planning is asking for 8.1 cm in the couch lateral. Like in here we have 7.5 and 7.1. lateral ISO, then you should be able to see 8 cm. فالآن السؤال, how much do we accept before we go back and we realign the patient? ما بعرف إذا في عندنا الآن we love our therapy partner, we love our radiation therapists, بس في بيناتنا كده يعني عداوة, we go head to head. We have seen, and this is very recently, يعني تقريبا قبل سنة, we have seen 5 degree of rotation, we have seen 7 degree of rotation on the couch, and then we treat. Well, radiation oncologists, we're okay with that. لأنه التفكير إنه as long as I am aligning the tumor. So who cares what happens in the different, everything else. If I need to do 5 degree rotation or 7 degree rotation or pitch or roll, إيش المشكلة? What's the problem? And the physicists were pulling, no, we cannot do that. We have to put a limitation. We're going to tell you why we need to put a limitation before we go inside and reposition the patient. I'm going to show you in a minute with a schematic diagram. But what we ended up agreeing on is definitely you can see here with 2 degree rotation, the area or the record amplification did not flag me, but with 2.1, it gave yellow. So we set 2 degree as our cutoff limit before we go in and reposition the patient. الآن أكيد السؤال is 2.1, it's just 0.1 outside the tolerance. Do we really have to go inside and reposition the patient? Here comes the discussion between physicists, with doctor, with therapist on the COM-beam CT, on the Linac station, Linac control when you do the COM-beam CT. Is it worth it or not? Definitely, I would say, just looking at this number, I would say it's not worth it. But if I look at the number next to it, there's a 2 cm difference for this particular day. So then something is wrong with the patient positioning. صحيح? And absolute vertical is 2 cm more than expected. You have to look at the patient not just as a number. Remember, we mentioned this yesterday with 4D CT. Computer will give you numbers, but you need to know what's going on inside the patient. But we did put a cutoff at 2 degrees. And after 2 degrees, we have to reposition the patient. إذا هي على الحفة 2.1, 2.2, we look at other parameters. We look at patient in general. يعني مو رح نضيع وقت الثيرابيست داخلين طالعين if we think it's not going to affect the plan too much. And as I said, definitely we've seen 5 and 6 degree couch position. And then you have to do a department protocol. What is acceptable in your own department before you go inside and you align the patient. So we agreed at 2 degrees, and then after that, we have to go inside and realign the patient. And the question is, why do we bother? يعني إذا إحنا الفوكس تبعنا هو التيومر, why do we bother going inside and aligning? ما نخلي 6 degree couch take care of it, and we're done. So this is an example where we have a long tumor. It's very small and tiny. يعني الpoint والcontour غطى على الtumor. You can't even see it with the contours. And let's say we have a beam going through here, and the beam is barely missing the esophagus. If you do a 5 degree rotation, and I admit this is exaggerated from dramatization, right? We're still focused on the tumor. So the tumor is getting the expected dose. But now the esophagus is in the path of the beam. So what the plan says the esophagus will get is no longer valid. And people will probably identify this as a central tumor. And so we have to really pay attention to esophagus dose and bronchial tree dose as well. So if we have a lot of correction in the rotational direction, the tumor will still get the dose. Don't worry. So the tumor will be treated, but the dose reported for the organs at risk will no longer be valid. So we don't know, right? What do you think? And then remember, when you're doing SBRT planning, you're trying to save 1 degree and 1 centigrade. So you're trying to save centigrades as much as possible. And then all of a sudden, rotating the patient like this, and completely the relative location of organs at risk is different. And other question, actually for lung, we never do full arc, we do half arcs. we still have the same problem. We still have to worry about a lot of rotational discrepancy. لأنه it's the same principle. إذا عندي arc وعندي organ at risk sitting next to the tumor, it's getting some dose from the arc. It's either getting exit dose or it's getting scatter dose, depending on how much time an organ at risk is inside the arc. And if you change the location of the organ at risk relative to the arc, it might be seeing more beam on time. 30% of the arc is seeing the organ at risk and everything else is just scattered dose. It could be that it's seeing 60% of the arc, seeing the organ at risk. So it still applies, even if you have arc treatment, not just IMRT style treatment of or SBRT. And that's why we want to reposition the patient. Don't use the 6-degree couch blindly. That's the idea. Your tumor will get the dose because we're concentrating on registration on the tumor, but the relative location of the organs at risk to the tumor will be different. And hence the DVH you have, your organs at risk dose will be different. Wallahi, I cannot stress this point enough. لأنه we had this discussion. And by the way, until we put this dramatization for people to see, people were accepting 5-degree, 7-degree in couch rotation on the treatment table. I'm like, ya Jama'a, we cannot do that, right? We have to think about patient as a volume. And when you're rotating things, the location will be different. Now, let's say we're doing this spine SBRT. And if you notice, so this is 2 images. We have the CT SIM image overlaid on the CBCT SIM image. And definitely you could see different shadows, one representing a CT SIM, one representing CBCT, هاي الكتف, the shoulder blade. Definitely you can see the different parts of the arm. But then look at the spine over here where we're treating. So for spine treatment, the focus is the spine, واضح, which means إنه ممكن تعمل الإيدين. But don't be too relaxed, because if the patient's arms are completely in the wrong direction, either too tight or too relaxed, and muscles pulling the back will be different, and you would have different arch in the back of the patient, which might slightly affect your spine. So we're not going to spend too much time on getting the exact arm location, as long as the spine is aligning perfectly well. The organ at risk clearly here is the spine itself. We're treating the vertebra. So if we're aligning the spine and we're aligning the bone, we're good to go. Okay,
there's a question about translational error. Nur al-Huda is asking, what is a translational error?
أيوة عزيزتي نور. Translation هو بالاتجاهات الإكس واي and Z. So عندنا translation ممكن يكون باتجاه table in and out. إذا هون this is the linear accelerator, تمام. So translation باتجاه in and out, أو translation بيمين يسار, right left, or translation of anterior posterior. يعني table up and down, table in and out, or table to the side. And this is my linear accelerator. الروتين أو البitch أو الترانسليشن هو يعني الكاوتشز من أيام بدايات الراديشن ثيرابي بتصحح لك in out, right left, and up and down. So another question. Ben, are you ready for the poll? So I know this is not SRS, but I need to drive home something. So bear with me. And the question says, for craniospinal SRS.
Before the question, Sahar is raising the hand for. So Sahar, go ahead.
Yes, I have a question about the translational error. Do you apply a 2-degree as the maximum limit as rotational error?
2-degree, we apply it as a limit before our therapists have to go inside and realign the patient. So we apply all corrections. So I can 0.1 degree, well, I can 2 degrees. You apply them and you have to, right? But 2 degree هو الcut off.
My question.
لغاية ما يروح الثيرابيست جوا
this is my question.
Reposition the patient.
This is my question. Is you confirm the translational error as 2 degree for as the rotational error? Do you accept more than 2 degrees for the translational errors?
So translational errors حيكون في 2 mm and you can do 2 mm, 3 mm or 4 mm. يعني هاي in and out, up and down و left and right مثل ما حكينا. إذا النك كانت with a pitch فقط. الكاوتش cannot correct only one part have a pitch وباقي الجسم طبيعي لأن الكاوتش كلها راح تتحرك هيك. بس الchest تحت عند اللنج عند السايفويد ما في رول. You cannot move one part of the couch and yes, rotational error is when we request the therapist to go inside and correct. It's واضح like what did they do? How did they put the patient on the table? If 2 centimeters to me is too much. Let's now ask this question. Again, this is an SBRT lecture, but I'm trying to drive a point. And we know what the point is after we answer this question. Craniospinal SRS is easier to set up than SBRT. ليش؟ لأنه orthogonal pair of images is needed only. خلاص تاخد AP or we do orthogonal pair and single CBCT scan. ممكن إنه it actually depends on how well a CT sim did their job in aligning the patient inside the immobilization device. يعني حطينا الحق على CT sim therapist. ترى هم يحبونا قوي CT sim therapist. والجواب الأخير, you know what, this is an SBRT lecture. What the heck, I'm not answering this question. Actually, if you one person who this is SBRT, let's not go there. Okay, so we have 43% participation.
Let's wait seconds. Hopefully we reach 70%. 5, 4, 3, 2, 1. Okay.
All right, so we have 6 people who goes, we're not bothering with this question. This is an SBRT lecture. And we have a lot of 60% that say orthogonal pair and a single CBCT scan is enough. In this case, do we need a 6-degree couch for intracranial? Who knows? And 28% say that it actually depends on how well the CT sim. عندي إحساس people who answered C are physicists and people who answered B are therapists. So the answer is, it actually depends on how well the CT sim staff did their job. Cranial SRS could be very easy, the setup, or it could be extremely difficult because we're looking for really sub-millimeter differences. And as it happens, of course, I do have an example, and this is another recent example. So we had something that came out of the CT sim that looks like this. And if you look at the coronal image, you clearly see rotation in the head, rotation in the clockwise direction. And if I'm using the spine to indicate midline, تمام? فهذا الخط الأسود is my midline depending on the spine. And then I use, well, actually the ventricles هو لسه فيها زوايا أكثر. If I use the ventricles to indicate brain midline, then I have this angle and this rotation. Actually, I have more rotation than here because it's not really at midline. طيب, the neck is well immobilized and midline. The head, few rotation. And you can also see the distance between those dots that we use for a stereotactic mask. From one side of the head, from the right side, it's closer, and from the left side, it's further away. طيب, نيجي الآن للإيمج هاي. This is an axial cut of the same patient, and we see 2 things. We see a roll, but it's very subtle. يعني الواحد بده يركز basically you need to be looking at enough images to you don't see it here because it's less than a degree. And we also have translational error. الأسهم هاي طبعا طايرة في الهواء لحالها. You could see that the patient head is not centered in the mask. يعني ال patient head أقرب لليمين منه إلى اليسار. So he's not centered within the mask. There is a roll here and there's a rotation only in the head. The neck is, mashallah, perfect. This is what we have from the CT sim. And remember what we have to do On the treatment side, we have to reproduce the exact setup that came out from the CT sim. The plan was done on the CT sim image, and now you have to reproduce it. So if the patient is crooked, you have to reproduce the crookedness. كثير أسهل إنه we reproduce something perfect. يعني the patient is midline, الليزر جاي بنص الأنف بنص الشن, you go down. It's very easy to reproduce that. It's very difficult to produce الأشياء المعوجة. لأنه واحد بيحكي طب is this كفاية ولا كده كفاية ولا كده, you don't know. What should have happened that this CT scan should have been caught by the CT sim therapist, and then they re-CT scan the patient, but that didn't happen. The planner / physicist should have caught this and then asked for a re-simulation, and that didn't happen. And now it reached the Linac table. So now we're trying to reproduce. And the idea is, you could say, oh, what's a big deal, you know, right? We just align put the patient in the SRS mask, and then we reproduce the same setup. For this particular patient, and you can see the date here, it took 6 CBCT images in order to reproduce the same crookedness. And by the way, باستثناء the very old masks for stereotactic that were made from plaster, and we actually had to cut them through with a chainsaw to open them. All the masks that we have, regardless if it's whatever the vendor is, right? فيهم شوية play. يعني if you put a little bit of pressure على اليمين ولا a little bit of pressure على اليسار ولا البيشنت راسه شوية مايلة يمين أو يسار, the mask will actually allow you to do that. And you need to catch it within the images. So now I'm just going to go through 2 images only and see what and how the scan changes. So this is one image, and this is the next. This is the same patient on the same day. And the mask fit nicely, صحيح? But you can definitely see, now when the CT sim therapist put the patient, they put him or her, I forgot, put the patient and aligned well. So they were actually put a nice alignment, بدون رول. However, this is not correct. ليش؟ لأنه the CT sim image was crooked. And now we have this one alignment, but the crookedness in the wrong direction. It should be in the other direction. So it took them 6 CBCT images to align the patient. So you can imagine, right? It can be easy. SRS cranial setup can be easy if everything is aligned well and you reproduce the alignment on your Linac. If whatever comes from the CT sim is crooked, ولازم أنت to reproduce a crookedness, you're going to spend at least an hour trying to align the patient. فالنقطة الأصل هو CT simulation. You really do need very experienced CT sim therapist وعندهم الوقت الكافي to do proper job and proper alignment. ومثل ما حكينا, if you don't give the masks enough time to stabilize, تقريبا they require between 15 to 20 minutes. لينشفوا and ياخذوا the actual shape, and they have less play. فif you put the patient in the mask, تستنى شوية صغيرة, 2 or 3 minutes. You do a very quick scan, حتى لو كان like 1 millimeter scan for the brain, it's a small volume, you're done quickly, and then you remove the mask, and it's less than 15 minutes. Once you remove the mask from the patient, it will cool down and it will take a different shape. You really need to give enough time for the mask to cure, يعني ينشف وياخذ الشيب الصح. ومثل ما حكينا, pay attention to that shin. Shin is crucial. Well, last week, as I mentioned, we had a continuing education session from one of the vendor representatives on SRS masks, and he suggested, which is actually a good suggestion, to create a bite as part of the mask. A bite منه فيه البيشنت يفتح تمه شوية صغيرة, and then using a pen or something, we push the mask slightly inside until the patient can, with the teeth, يسكر. And this becomes like an intrinsic bite. So this is another way of trying to reproduce the same position. So imagine.
Bilal is asking
It took 6 CBCT images to align this patient. عفواً تفضل.
So we have Bilal asking, let's assume that the CT sim scan was really good. So whether we don't need to do CBCT?
لا طبعاً you need to do CBCT. لأن the mask can fit. So this is a mask that's fitting nicely on the patient, but then look at the rotation. Until you do a CBCT, you cannot see if you have a good rotation or not. Orthogonal images, lateral والAP راح يعطوك gross alignment إنه البون looks good يعني 1 degree rotation ولا حتى لو 0.6 degree rotation. You will not see it إذا ما عندك volume scan, CBCT scan. It is a must if you're doing stereotactic, so كان intracranial ولا extracranial. You need to do a CBCT scan. يعني البيشنت هون aligned nicely مع الماسك والماسك مسكر بس definitely different rotation. As a rule of thumb, if I can see it with my eye, this is definitely more than 1 degree rotation. And definitely we can see it with our own eyes. So easily this is 1 degree or more rotation.
Mahmoud Al-Fishawi, can you elaborate on your question?
Any question?
He's asking about SRT.
My question is if there is no alignment for SRT, we can go on treatment, but for normal treatment, we should rescan. It is okay or?
Again, if we don't have proper alignment with SBRT, we have to align.
Yeah, we have to align. But if the brain is not fit well or something like that, as you mentioned.
Anyway, that's why you do the CT scan, the CBCT scan, and you try to fit the patient in the mask. It's not fitting?
No. If we make it and the patient is well fit, but not alignment, because it's not simulation good. We can treat
السيميوليشن والبلانرز ما مسكوها والفيزيائيين decision, do we treat or do we re-CT sim? لا الطبيب قال we treat بس we have to reproduce the same crookedness.
Okay.
It took them 6 CBCT images. No, this is good. It is good.
For normal treatment اللي هو fractionation مثلا 25 fraction أو 30 fraction.
And properly aligned. ايش بسموها هاي positioning بالCT simulation جدا for all patients صراحة ولكن بالأخص البيشنتس تبعون stereotactic so intracranial ولا extracranial that we have to spend a lot of time أو enough time نضمن إنه patient is well immobilized well aligned. ترى هما 2 different things. إنه البيشنت ما يقدر يتحرك whatever أنت حاطط فيه مربطه بأشياء مربط راسه. Immobilization تتكلم عن patient cannot move. الalignment هو alignment على الطاولة أو في عندك rotation فهم 2 different things. تمام؟ فالidea إنه 6 degree couch ما بتحل كل مشاكلنا. We have to really be careful. وكمان ما نقول إنه هذا stereotactic أو intracranial أسهل من SBRT ما أحتاج أعمل CBCT. You know, actually you do need CBCT حتى for intracranial.
What's about?
فكرة اللي بعقلي.
Okay.
الآن في سؤال. Do I need a 6 degree couch for intracranial? وأنا مرة ثانية I'm sorry this is not an SRS lecture بس عشان والجواب نعم I do need a 6 degree couch for intracranial. ليش؟ على عمر الجهاز الكاوتش بتصير ما عندي 6 degree couch I cannot correct for it and it's very crucial بالintracranial I correct even for these things. So حيكون في عندي هذا اللي احنا بنسميه البيتش. المريض aligned well it's no one's fault. الCT sim therapists عملوا شغلهم صح، الليماك therapists شغلهم صح، كل شيء تمام، بس هو الساجنج من وهاي actually we see it as physicists when you do monthly Q طاولة بتشوفها sagging. كيف بنشوفها sagging؟ بنشوف الليزر not aligned وفي ناس ممكن يفكروا إنه الليزر مش aligned لا actually the table is sagging. So you need the 6 degree couch to correct for this pitch if you're doing it.
So exact track, whether exact track is enough for SRS?
I don't have experience with exact track. إذا exact track تعمل لك 6 degree couch mobilization عفوا alignment and you do CBCT, then this should be enough. I want to see a volume image, and I want to be able to correct in rotation, roll, and pitch. So whatever exact couch, whatever exact track is doing, if it gives me a rotational correction بالثلاث اتجاهات, and then I have the CBCT اللي جاي من linear accelerator بطبيعة الحال, then this should be enough. Again, احنا مش عم نحكي عن اسماء vendors معينين انه I don't want to push one vendor over the other, but this is what you need. You need a couch that can correct in 6 dimensions, and you need a CBCT image. هلا we're actually concerning when we're thinking about getting ايش يسموها بين الله يسيفوني skin match.
SDRT.
ايش الدي ار بي؟
SGRT.
SGRT احسنت. Surface guided شغله اضافيه للثيرابيست تساعدهم يعمل. And you can use the SGRT حتى for other patients who are not stereotactics. You can use it for breast patients for sure.
Correct.
Whatever you can do to help the alignment on the patient is needed صراحة.
نعم. بالكوستروفوبيك ونستعملهم open mic.
Yes, you can do that.
Precision is enough.
Is what is enough, عفوا?
سؤال هشول, what's your take with using open face mask and precise mouth bite for claustrophobic patient? Is it acceptable?
So yes, أهم شيء إذا أنت عندك good chin alignment, good chin definition, or if you have a bite, شوفي, if we can fixate the upper jaw with the chin, وعندك a good set يعني alignment مع الhead rest, you're done. That's what I need. كده. So I can do the chin and a bite. ففيك تعملي ال open alignment. And remember طبعا أنت you're also doing. Okay. Oops. So we still do sometimes use orthogonal pair for quick alignment. خاصة if we're doing. This is what I got from our therapist, and I asked them what is the workflow. So for brain, they don't do orthobody, they do a quick orthogonal to make sure على الأقل we have gross alignment. يعني the patient جاي aligned 100% من AP and lateral. بعدين they do CBCT, and the CBCT we're doing at the rotations or fine tuning. في عندنا طبعا we're doing DIBH, and you're taking CBCT. And the patient cannot reach the same DIBH level. The box تبع tracking the breathing is put in a different location. If I put the box that's tracking the breathing cycle in a different location, I get a different signal. إذا بنعمل gating, it will not affect gating. Not too much. I don't have to worry. Like it will affect the amplitude تبع the breath. So حتحس إنه DIBH is different. If the DIBH is different, معناته lung volume is different. معناته I cannot do my alignment. So we have to coach the patient. طبعا إذا عندنا الفيدباك screen صراحة بتشيل معظم المريض, and they cannot really hold their breath or they cannot hold it. And in this case, unfortunately, we have to do a reseat TSM. We don't do it very often. ممكن أقول مرة بالشهر DIBH for stereotactic. Prostate and pancreas, we align with fiducians. The pancreas, doctora, she has specific instructions and workflow. She wants to align with the spine, أول شيء. So we focus on spine. And then we go and focus on the fiducials and the pancreas. Alignment بالpancreas والfiducials. إذا كان spine alignment أكثر من سنة ونص, she does not treat. هلا إيش الأسباب؟ ممكن يكون في عندنا a lot of gas build up بالabdomen. It's pushing يعني pancreas head and pushing everything to one side or the other. ممكن يكون patient MAC. طبعا they have to follow a certain protocol قبل ما يجوا على clinic for treatment, but not all of them do that. Most of the problem we see is a lot of gas buildup. So we don't treat. What she does, and she has a very nice, clear workflow, is a patient we cannot treat because we have centimeter difference with the spine after we align with prostate and fiducials. بتقول للبيشنت ينزل and he's just walking around وبعد بيعطوه anti-gas pills. السؤال, why do we care about spine alignment إذا إحنا we're concentrating only علىها, and it's a very good rationale. في الabdomen you don't have fixed organs. everything is moving. فإذا الأعضاء الداخلية are moving so much بحيث البون is aligned أو misaligned by 1.5 cm or more. معناته we cannot guarantee in organs at risk dose. So remember, we can always register to the tumor, in this case pancreas مثلا, and we get the dose to the tumor صحيحة. But what about the dose to the small bowel? Will it dose to the kidney or dose to the spinal cord if things are really moving a lot? So that's her rationale. مرة تانية, the workflow that she uses for pancreas, we align with the spine, we assure that spine alignment is proper, and then we go to the pancreas and the fiducial, and then we align those. بعد ما نخلص الalignment مع البنكرياس والفيدوشال نطلع على الصورة الكبيرة and we look at the alignment with the spine. If it's 1.5 cm and less, بالإضافة طبعا she looks the bowels إلى آخره, بس she mainly concentrate على spine. إذا 1.5 cm or less, we go ahead with treatment. If not, نطلع على الأسباب. And most of the time, الأسباب is buildup of gas inside the patient abdomen. So we try to remove the reason, and then we put the patient back again on the CT sim table, and then on the treatment table, and we CBCT, and we do it again. Only one patient that we had to re-CT sim in the last 5 months, I think. And for some reason, the gas buildup كان دائم. يعني حتى البيشنت روحنا, we asked them to go to back home, come back again, not to eat gassy foods, إلى آخره. But the patient was consistently had way more gases in the abdomen daily relative to the CT sim. So we figured في شغلة اختلفت بحياة البيشنت now that they have a lot of gas buildup in their abdomen. So we had to re-CT sim. Prostate, we align with the fiducials. And for gated lung, linear accelerator that we have, when you do fluoroscopy and you have a gated window, during fluoroscopy, you can see the tumor is moving, and then when the tumor is within the gated window, في مربع that turns yellow, and then when the tumor goes out of the gated window, it goes off. So we do بعد ما نعمل الاموبلايزيشن ونعمل الفيريفيكيشن الى اخره, we do a fluoro under gating ونشوف انه الbeam can actually turn on and off in the expected gating window. Lastly, then we do physics review once a week for all patients treated in the department. Often we didn't do that. We do physics review of the images, approval for setup, and clinician final approval. Both physics and clinicians have to approve the images. Otherwise, the therapists have to keep on repeating the setup or the CBCT, and then we have been on. So we have a physics chart review once a week that we do offline. However, for, as you know, SBRT cases or SRS cases, usually you have less than 5 fractions. In this case, then we make sure that the physics review is appropriate. تمام؟ يعني المريض ما يخلص without physics review. فالآن السؤال اللي يطرح نفسه, why do we need physics to do offline review? The patient has already been treated, already on the machine. You have physics and doctor who review the images before beam on, and then also you do have clinician review of the images once a week. So why do physicists have to review the images as well? The answer إنه the SBR, the physician, the treating physician, is only concentrating on their own patients. Therapists, when you have SBRT, SRS physicist reviewing all patients treated in that week, you could actually see any systematic error. And the reason we were able to catch side chin not proper in those images that I showed you, because you have a physicist who's reviewing all the SBRT patients once a week. So you can catch systematic errors. The patient's already treated, صحيح? So the benefit now is catching any systematic error coming from the CT sim or coming from one machine, and then improving the workflow. ترجع بتقول, يا جماعة, I think بدنا شوية education, continuing education, نجلس مع بعض نتكلم بموضوع معين. And then you have the team in that machine or مع الأطباء نفسهم, and you're improving the process. The process is always improving. So an offline image review for a physicist is to look for the overall workflow of your patients, of your department. So it's good to have a physicist who is an SBRT SRS specialist who is going through all the images. Do I have systematic errors or not? We will have random errors, طبعا, but we're not looking for random errors. We're looking for any systematic errors. So that is the summary. Proper alignment. كل شيء يبدأ من CT simulation. Use as many CBCT images as you need to align your patient properly. حتى لو كنا نتكلم عن intracranial SRS. A 6-degree couch really solves a lot of problems بالrotation والroll والpitch, ولكنها ليست solution سحرية. It's not a magical solution. You need to put your patient properly first, and then you say, let's fix rotation هون وهون.